Welcome to our series of Healthcare Seeing Google Plus Hangouts, where we sit down with top leaders in healthcare IT. Before we begin, I want to remind those watching live that you can submit your questions on the event page for this Hangout. We'll do our best to answer them during the event. I'm pleased to have Alan Portela here with me. Alan Portela has more than 25 years of experience in bringing groundbreaking medical technology solutions to market. Alan became CEO of AirStrip in 2011, and prior to joining AirStrip, Alan was CEO and principal of Hybrid Clinical Transformation LLC, where he developed successful EHR adoption strategies for the U.S. military health system and much of the VA. He also served as president and chief strategist at Clinicomp International and in senior executive roles in several innovative healthcare technology and service organizations. And I must admit, he's one of my favorite people to interview. He has great insights, so I'm really pleased to have him here with me today. Welcome, Alan.
Thank you so much. Thank you.
So let's get started. Tell us the Cliff Notes version of the AirStrip story. How did it come about, and where is it today?
Well, it's very interesting. The company started about 10 years ago, and primarily we started in obstetrics, accessing remotely fetal surveillance on mobile devices. We were the first application to receive FDA clearance, and after a process of about 9 years, we received the patent it's a methodology patent to re-render medical devices on mobile devices natively. Today, we cover about 1 out of every 6 babies that are born in the U.S. are monitored by physicians using AirStrip.
Wow.
3 years ago, we took the medical device side to cardiology and also patient monitoring, and we started monitoring patients outside of the hospital coming in an ambulance with EKGs. We did that also with FDA clearance. We did the same thing monitoring patients in intensive care units, and also with FDA clearance. And about 2 years ago, we decided that we needed to go beyond just medical devices. Since we were already a big player dominating that industry, we decided to go into mobilizing, creating a view for electronic medical records. And as we sorry.
Real quick, before we get into the where you took it, I remember you talking about the EKG, and one time we met, and I remember you saying something really interesting. You said putting an EKG on a mobile device isn't as easy as it sounds. Why is that the case? And why? It seems like it's just an image. That's what many people like to argue. Why is it so hard to put an EKG on there, or even an ultrasound for that matter, right?
Yeah, so of course, as you said, it sounds very easy. So there are 3 ways of bringing mobility for medical devices. One would be Citrix, which is a terminal emulation. The other one would be web-based access. And the other one is accessing those images in a native form. If you want to start monitoring patients outside of the 4 walls of the hospital, it is important that you keep a diagnostic quality resolution. That is primarily something that you can achieve if you do natively, because you leverage from the strength of each operating system, iOS, Android, Windows, and the ability, as you look at that image, you zoom in into that image to keep the medical aspect ratio.
So would the FDA have cleared it if you hadn't used a native app? I mean, are there FDA cleared diagnostic tools that aren't native?
Well, not to my knowledge. I believe that most of the applications that are FDA clear, they're native. If you look at imaging, it's the same situation. When you look at X-rays and you look at ultrasounds, other diagnostic quality images, they are native. And there are a number of vendors that are providing either Citrix or web-based access that do not go with FDA clearance, because they claim that the intended use is just for consultation, not to make a decision that has diagnostic quality. There is another aspect of this. If you look at where we are going with medical device mobility, now we're starting to add algorithms on top of the EKG, on top of fetal surveillance, on top of patient monitoring. So now we can start proactively providing prompts and notifications to those caregivers. And if you start with a foundation that is not FDA clear, you will never be able to get clearance on your alerts, prompts, or notifications.
Wow. No, that's a really interesting insight. There, if you go with just the scanned EKG image, you're not going to be able to do that diagnostic stuff. One, because you're not FDA cleared. Two, you don't have the data to actually do it. So that's interesting. So let's go back to so then you mastered the ultrasound, the EKG, and then you had a bigger vision. So where are you headed with that? I think you said 2 years ago you started with this. Is that right?
Well, yeah, it's actually 3 years ago we started conceptually with this and then we spent a whole year really taking this product that was a result of a partnership with Palomar Healthcare. When we were doing medical devices, we realized that a number of healthcare organizations started consolidating, and you saw hospitals merging with other hospitals or collaborating with other hospitals. You saw also them acquiring post-acute care facilities, getting more into the community-based care. And as consolidation took place, we started realizing that now every vendor, every hospital that had different vendors for EMRs or medical devices, they started inheriting a mess of systems and a bigger problem on interoperability than what they had before. So as we were looking at medical devices, we realized that a doctor is looking at a real-time or a near real-time wave coming from a medical device, and that the reality is they didn't care what system was the source system. You could be running on Philips monitors, GE, Spacelabs, and others. And 3 years ago, we decided if we can create a visualization tool for the EMRs that we can provide access for physicians, whatever they are, on any record that they're looking at, and we can integrate all that data on the front end, that we will make a significant difference. So we decided to go in that direction, and was the beginning of what we call today AirStrip One. In essence, what AirStrip One became is it's one platform, one application to access multiple data types, multiple vendors, multiple care settings, and to be able to provide everything on one platform, one app for the physicians.
So I remember this discussion. I think we met 2 or 3 years ago when this was just a new idea, and you said something that I've quoted many times, that that the EHR world will have multiple vendors. That it will be a heterogeneous environment. So it seems like you're executing on that vision. Is this read only, or is this two-way? You can read and write to the EHR. What's been your approach so far with this?
So of course, and I remember that conversation that you and I had, and also we were talking about what we thought were going to be the trends in the industry, and I recall, and there is a connection to the question. We were talking about the fact that with the shortage of caregivers, an increasing population, sicker population, reduction in reimbursement rates, that obviously, unless we come up with some innovation and interoperability visualization tools, that we were going to implode. So what we started doing is really, we started in one direction, collecting the data from all these systems. But as we were doing on the medical device side, we decided many years ago that we needed to have the ability to write back. On many of those systems on the medical device side, it allowed us to do edits and confirms to be able to work on cardiology and other of the systems that we have. So we decided to take the same approach, and as we work with the EMRs, we realized that the last thing we want to do is reinvent what they have done. And the idea, and what we're doing right now with some of them, is starting to work on getting their APIs on top of our platform. So when doctors are entering an order or they are writing a note, that they're really going to that source system, but it is transparent to them because they're accessing that through our platform and through our application. It will be transparent to them.
I think that's interesting. Obviously the goal, the holy grail, is to be able to read and write. But I think we also discussed this 2 or 3 years ago. Said, well, will the EHR vendors let you do this? And the question is, I think your answer, if I remember right, was, well, they're going to have to. So 2 to 3 years later, has this played out? And are they working with you, or do they hate you, or what's the EHR vendor's stance towards what you're doing?
Well, it's a good thing that the last time we talked you didn't phone me. Otherwise, you would have seen that I have more gray hair today.
Mine's
But
going back too, so.
the reality is that one of the consequences of provider consolidation also is the fact that the providers are gaining a lot of power. As you see organizations of 100 hospitals and hundreds of clinics, and those organizations having multiple vendors, the reality is that now those providers are in a position that they can enforce interoperability. So of course I will say that 80% of the vendors that we know are collaborating with us around customer requirements, around the customers requesting that. There are about 20% that they're not collaborating, but I'm not going to mention their names, but those are the ones that are not going to be around for a long time. And if you realize what goes on here, these vendors, they need to open up so they can protect their customer base and they can live in this environment. What I tell the providers is that for the next 12 months, they have the power. After that, the power will be up to us, the consumers. And we are not going to go to hospitals that do not share our data and where we have no access to our data. So the consumers are going to be the worst nightmare of providers if they don't enforce interoperability.
Interesting. That's really interesting. Interesting that 20% don't interoperate with you. But it seems like the key is, though, that you have customers that are asking it from the EHR vendor. If you ask directly, you'd get the cold shoulder, right? Does it have to be customer driven?
Well, it always helps to have the customers working with us, and it's very interesting for many of us that have been in healthcare for a long time. I mean, this is my 22nd year in healthcare. I have been at 22 HIMSS, which is not a pleasant experience. But the reality is we all know each other, so we don't hate each other, we all know each other, and everybody has the intention of opening up and really sharing their APIs, giving you all the data that you need. So in theory, 100% are supporting the concept of interoperability, but in practice is when we go to the customers that we do it on a case-by-case basis. And the key, of course, is always making sure that when you do interoperability and you're writing back or you're using their tools, you're not coming up with new tools that potentially could become a patient safety risk.
Interesting. So, I mean, that's the other thing, when I remember one of the unique aspects that you have at AirStrip that most other mHealth companies don't have, or even interoperability companies, is they don't have an Alan Portela that's been to 22 HIMSS, that knows all the EHR vendors. I mean, what would be your advice to a startup company, maybe someone new to healthcare that doesn't have the 22 years of connections to be able to work with these EHR vendors?
Well, thank you for the compliment. I think that the key here, this is a very difficult time in the industry. When we were talking about healthcare reducing reimbursement rates and costs going up, the reality is that the new patients coming in, either baby boomers and patients from Affordable Care Act, they are going to come in at a reimbursement rate below cost. So hospitals are cutting down 30% of their operating budget over the next 4 years, which means for a startup company today, it's becoming very difficult for them to survive. It's very unfortunate. So my recommendation is that this is where collaboration goes beyond interoperability, is looking at what ecosystem you can fit in, where you leverage from other vendors that already are gaining traction and have been able to make an impact on ROI, helping on care coordination, so you could put your piece of innovation into their platforms. That's what we're actually doing on AirStrip One platform. There are so many innovative companies that are coming to us, including partnerships with academic medical centers that have developed incredible algorithms for decision support that they want to take to market. So basically, we're all creating an ecosystem, and we're using our platform to take that into the market.
Interesting. Yeah, I was going to ask if your platform's open to outside developers. Is it wide open, or you have to submit it? What's your approach to working with outside developers, indie developers?
The platform is open to any developer out there that wants to come and work for us.
So it's not open. Okay.
No.
Interesting. So, one other thing that's interesting is you talk about, you did it with or at least you're working on it with the EKGs and the other data with the medical device side and making them smart. And you also talk about the need to lower costs. And everyone that talks about lowering costs throws out that beautiful buzzword, healthcare analytics, right? Are you going to apply that to AirStrip One? And I mean, I think you have to apply healthcare analytics. So I guess maybe the question is, how are you going to apply that? What are you really going to do with the data in AirStrip One, or is it really just about accessibility and interoperability?
Well, if it was about just having access and interoperability, access and visualization, the reality is that I could say that we are done. But the reality is that if you want to really impact workflow, when we have millions of patients coming in and few physicians, few caregivers to take care of all these patients, the reality is that you need to be able to make a huge impact into workflow. And in order to impact workflow, there are two very important components. One, you mentioned it, is right back. I look at something, I need to take action. I need to be able to document what is that I'm observing. The second one is I need to be able to be proactive versus than reactive, because we don't have enough caregivers to be on top of everything that goes on. So analytics becomes a mission critical component of improving a workflow for care coordination teams. So our position is that we started working very hard on interoperability. Of course, not because we felt that that was our core business, but because of necessity. Because if you go out there and you look at the HIEs, they give you a CCDA file that is usually a subset of what you really need to be able to make the right decisions. So we needed to start going deeper into collecting data that was proprietary for each system, proprietary for medical devices. And the moment we started collecting all that data, we said, well, now we have data that if we start partnering with companies that provide analytics, we can give them data that they never got to see before through the standard HIE companies. If you look at our medical device data, remember how we started. I said that we are re-rendering medical devices on mobile devices natively. By that I mean that we take the waveform and we convert that into zeros and ones that we re-render on a native device. That means those zeros and ones, now they represent a lot, that if you put an analytics tool, you can do data mining in a way that it has never been imagined before. So we are very excited about where this is going, because we are at the center of all that.
Interesting. I like the idea. I mean, because essentially you're re-rendering the EMR data into a view or into a platform that lets you do things with it that you weren't able to do on the native platform, or at least they haven't chose to do yet. Interesting.
Exactly.
Go ahead.
Key that I wanted to mention is that many people say, well, who is your competition? And I wanted to say something about that. When I told you that providers are consolidating, and they inherit a mess of multiple systems. Each of those systems will have a mobile solution. If you start mobilizing each component of the mess, all what you do is you mobilize the mess, but you're not solving the problem of integration. That's what we do. We are agnostic.
Interesting. So, I think the other interesting question is, so now you're aggregating all this EHR data from multiple systems. Do you have to be 2014 certified, or can you piggyback the EHR vendor certification because you're writing back to the EHR vendor, or do you just not deal with meaningful use at all?
Well, it's the key is the way you asked that question. You said 2014. So, of course, up to this point, we're creating a front-end integration tool, something that people that were looking at meaningful use requirements, they were never even envisioning that such a tool could be created. But as we start looking at the next stage of meaningful use, we feel that when it comes into outcomes improvement, we are going to have a significant role on stage 3, and we already are trying to influence the federal government so we can have a significant play on outcomes improvement that comes from analytics, that comes from data aggregation. So I think that we are probably going to be the core tool as you look at stage 3.
Oh, interesting. So I've actually been writing a number of articles recently about meaningful use and somewhat saying it's on the ropes, but also saying something that I think I've been reading more and more. In fact, there's a whole company that's created a product called TrueMU, which they said they found as they talked to doctors that the meaningful use requirements weren't even as high as the standard of what they really wanted to achieve. The doctors would expect more from themselves, and the meaningful use actually makes them perform worse because they're teaching to the test rather than doing what they could do and what would be possible with the data and what they'd like to do. So I'd be interested to hear, what's your take on what is possible with the work you're doing, and what are the outcomes that we could see from this mobile health work and other?
Well, so I would like to put to compare two things that have been around for the last few years. One is accountable care organizations, ACOs, and the other one is meaningful use. If you look at the goals for meaningful use at a very high level, it was all about data aggregation, data analytics on stage 3 to drive outcomes, to improve clinical outcomes. Accountable care organization was all reimbursement around improving outcomes immediately, specifically on the top chronic diseases. So those two initiatives were very much aligned. Everybody is driving towards outcomes improvement. But the third one that I want to mention to you that is related to what you were saying is ICD-10. So all of a sudden we had 18,000 codes for a value-based reimbursement, and the hospitals were getting ready for that, spending a lot of money, hiring people to really get into that point, spending money to be able to better take care of patients and get reimbursed on the value that they bring. And of all initiatives, the one that should have not been postponed is ICD-10, because now we're moving from fee-for-service to value-based, but we're taking all the codes that we were going to add, from 18,000 to 68,000 codes. So what happens is it's going to be very challenging now continuing the discussion on meaningful use and outcomes improvement when I'm not going to pay you for it. So, okay, so what is the key of mobility? Well, the way we see mobility is just an enabler of transformation, the same way that analytics tools are enablers of transformation. We at AirStrip have been the ones that are redefining mHealth. The M is not about mobile devices. The M is about the mobile consumer, the doctor, the patient. That's why we decided to take the same look and feel of what we were doing on mobile devices, and we took it to a desktop and a laptop, and that's when we decided to go with Windows 8 Touch. So now BYOD is really bring your own device. It doesn't really matter if it's mobile or not. Interesting.
So I think it is interesting, because when I look at the mobile health market, there are very few companies that are uber successful. And I keep hearing from a number of people, AirStrip is just killing it in the mobile health space. I mean, I think your numbers that we've seen, play that out. So why are you so successful and so many other health startups are floundering? What's the difference?
Well, it's very simple. If you go back to the idea of the mobile consumer being the doctor or the patient, and go into the idea that mobility is an enabler of transformation, the thing that I do is when I hear a hospital saying, we are creating a committee to look at mobile technology, I stay away from those. Because the reality is we need to look at what are their strategic initiatives and figure out what are the technologies that are going to allow them or enable them to achieve those strategic initiatives. The more emphasis you put on mobility as a technology, the more you lose track of what is that you're trying to accomplish. We just happen to bring mobile technology and integrate with a number of other technologies to be able to achieve those or enable those strategic initiatives and to enable clinical transformation. But yes, it's like if every hospital starts putting committees together for analytics, for cloud, for mobility, they always end up creating bureaucratic processes that is the last thing you want to do when you're trying to innovate. Don't create a committee.
That's interesting. But I think you also said something interesting. I think it had to do with alignment of strategic priorities, aligning your product with the strategic priorities of the hospital. It seems like that's what makes the difference.
Yeah, and this is a perfect example. Let's say that I sign a deal with a hospital group of about 100 hospitals and hundreds of clinics. They come to us and they want to buy the AirStrip One platform and the app. And then they tell us, how are we going to deploy this? Basically, I tell them, I'm going to deploy a team of doctors and nurses before we start the go-live process. And we are going to go to each of your markets and we're going to see what are the strategic initiatives for each of those markets. We always come back, and some markets is all about 30-day readmission penalties on cardiology. Some other markets is about glucose management. For others, it could be high-risk pregnancies. So there is not one size that fits all. We take the platform, we collect the data, and we start looking at the use cases around workflow for primary care doctors, for hospitalists, for specialists, and that's how we do it. And keep in mind, we use a SaaS model, so people pay on a subscription basis. If I don't do that up front and I don't set the expectations, then the customers don't pay.
Interesting. How do you convince them to let your team come and do that analysis? Is it just relationships, or I think that there's a lot of people who would love to do that analysis, but the hospital won't give them the time of day or the resources to check that out. How do you make that happen?
Well, we are, as you know, I have been around in healthcare for 22 years, and this is the first time, and I will say probably the last 24 months, that healthcare organizations are coming to us because they're having a huge problem of interoperability, and they're coming to us to come and partner with them to solve that problem. They need to satisfy physicians, so physicians will bring their patients to their system. The only way to maximize patient population is by keeping your physicians happy. So what happens is we are taking that partnership, and we clearly understand that we are not going to bring technology and just put it in front of them unless we know exactly what their pain points are. And I can tell you, physicians always get a negative reputation, but the problem is not the physicians. The problem is that vendors have never done a good job coming up with tools that are user-friendly for those physicians to improve their workflow. And unless you listen to them before you bring technology, you're never going to get that done.
Interesting. Well, unfortunately, we're out of time, but I want to really thank you for spending the 30 minutes with us, and I think you provided some really interesting insights into your company and the industry at large. So thank you so much for being part of it.
Thank you so much, John.